to the next speaker and introduce the next speaker. That will be Don Gibbons, a professor in the Department of Medical Oncology at MD Anderson in the Division of Thoracic and Head and Neck Medical Oncology. And Don's talk will be about exploring immunotherapy response and resistance in non-small cell lung cancer. Don, take it away.
Just sharing my screen. Can you see this okay? Can you see my slides?
Now we see the background of your screen, not the slide.
Okay, is that better?
It shows Outlook. I chose the PowerPoint, but all this, I mean, the way you see, yes, now it's good.
Okay, sorry about that. So thank you for the invitation, everybody. And I really appreciate those of you who are in Europe and France staying up so late to listen to the Americans on our side. I'm sorry that we can't be there to join you for this fantastic conference. These are my disclosures. So obviously everybody at this meeting knows very well the landscape of lung cancer and how it stacks up versus the other tumor types. I show this slide essentially to emphasize, though, the fact that we still, despite all the changes that have happened for targeted therapy and for immune-based therapies over the last few years, we still have a lot of progress to make because even for patients with localized disease, as shown in the blue bar here on the bottom, these patients still have a 50% chance of overall recurrence. And so we need to do everything possible to continue to push forward the progress that has been made in studies such as this, which was the first approval in the United States for immune-based therapy, showing that nivolumab, even in heavily pretreated patients, had the capability of inducing long-term durable responses in patients that last many years. And obviously for those patients who are in this roughly 15 to 20%, we don't need additional therapies. But for the other approximately 80% of patients, 40% of them have no response whatsoever. And intriguingly, there is this middle group that has some degree of response and really does benefit in terms of progression-free survival, but have acquired resistance over time that prevents them from obtaining the long-term durable responses. And in fact, this is true now across multiple data sets. From first-line treatment, where immune checkpoint blockade has been incorporated, be it checkpoint blockade by itself, in combination with chemotherapy, as in the Keynote 189, or in dual immune checkpoint blockade with nivolumab and ipilimumab, as shown in Checkmate 227. So in each of these cases, you see that there are obviously patients that benefit just from these therapies over the long term, but that many patients have acquired resistance. So it's incumbent upon us to continue to push forward, as many other speakers have spoken about today, to understand the heterogeneity in the disease and the differential responses. And so in trying to do just this, one of the many projects that we have been leading in the last few years is to try to understand the immune genomic landscape of early stage lung cancer. You saw some work from Dr. Kadara that he just presented, where they've really focused from a single cell RNA sequencing standpoint. In this particular project, the ICON project that has been funded by the MD Anderson Lung Cancer Moonshot, we took the approach of trying to essentially duplicate the Cancer Genome Atlas studies, but now with a real focus around technologies and platforms that would give us much more of an immune focus or an immune-centric sort of TCGA. And this was 150 patient samples that was collected over several years, where we have now long-term follow-up on these patients to go along with the multi-platform profiling of their tumor tissue, of the normal tissue, and of blood over the long term. And of course, the overall idea here was to characterize the immune genomic landscape of the disease, potentially establish biomarkers that we could use for clinical translation. And of course, at least at our own institution, to build the infrastructure and a comparator set of cases that we could use for biomarker-driven immune checkpoint trials, such as the NeoSTAR trial that Dr. Cascone presented this morning. And so one of the ways that we have gone about trying to understand this multi-platform data is to really now focus on outcomes, because the data set is more mature. And this was a particular study where we tried to understand if there were particular immune populations that drive long-term recurrence-free survival. And what we found, strikingly, is that individual populations, such as individual populations of lymphocytes, various T-cell subsets, were not predictive, but that when we took an integrated multidimensional approach, that then the aggregate functional immune phenotype of the tumor-infiltrating lymphocytes really did discriminate between two different groups, one with very good recurrence-free survival versus one that had much poorer immune recurrence-free survival. And the difference between these two groups really came down to whether or not there was an overall immune microenvironment that was one that was full of activated and effective effector T cells versus one where the T cells, be they have a CD4 or CD8 or even of a B cell phenotype, were much more overall suppressed. And these findings were completely independent when one looks at these flow-based analyses of the stage, the smoking status histology, and multiple other multivariables in the analysis. So really emphasizing that the functional immune landscape is most critical. Similarly, we've taken other approaches. In this particular approach, we're trying to integrate the data across the various platforms, be it RNA sequencing, proteomic profiling by RPPA, et cetera, to really understand if the data can be integrated across the platforms in a way that really would highlight or bring out unique correlations that we wouldn't be able to observe if we were only looking at RNA sequencing or only looking at flow. And so using nearest neighbors based approaches, we've been able to build a multi-clustered and multi-dimensional platform here where we can really dive down to deeper and deeper levels, looking at smaller and smaller clusters. And this has allowed us now to really explore the data set and to really understand if there are associations that are coming from various different markers, be those markers ones that are found out in the circulation or those in the tumor that are defined by sequencing or defined by proteomics profiling. And this just highlights one of these very specific clusters that comes out of the data, where we see a strong correlations between the immune markers found in the tumors, the extracellular matrix or markers that define what the matrix or the fibrotic nature of the tumors looks like versus signaling pathways. And so these are all approaches that we're taking to really try to better understand and better profile the tumors from these early stage patients, to understand what the natural course of the disease is, so that we can develop appropriate comparisons to the NeoSTAR data set or other similar early stage data sets, as well as late stage data sets from patients who are receiving immunotherapy, such as was outlined by Dr. Barlisi earlier this morning, so that we can really try to understand what are the markers that we should be using to define the disease, and most importantly, define patients who will respond to our current interventions versus those who will not. At the same time, all of these are simply associations. And so in parallel, we have been building ways to model immune checkpoint therapy in experimental models, so that we have the capability to move back and forth between what's happening in the clinic with patients and what's happening mechanistically, so we can try to bring forward new therapies that are not ones that are currently on the table. And so to do so, over many years now, we've been developing genetically engineered and syngeneic models. Many of these are based upon the models that are well known, such as these here, that have activated KRAS mutations, either by themselves or in combination with other mutations. This particular model series is defined by mutant KRAS and mutant P53. We have both the autochthonous genetic models as well as syngeneic genetic models, and that obviously provides us then the opportunity to manipulate the syngeneic models in a way where we can understand the cause and effect between what's happening in tumor cells and what's happening in the surrounding microenvironment and the overall phenotype. And in doing this sort of work now over the last decade, we have really defined a number of ways that tumor cells interact with each other, interact and actually direct changes in the tumor microenvironment, including changes in the extracellular matrix, the cross-linking and deposition of the matrix, and then interactions either directly or indirectly with the immune cells that define the ability of these cells to invade and metastasize. And in fact, for the remainder of the talk, I'm really going to focus around this one particular theme about the roles of the extracellular matrix. So one of the things that tumors do along with interacting with cancer-associated fibroblasts is that each of these cell types can drive changes in the stroma or the tumor microenvironment in terms of the extracellular matrix. And they deposit collagen, but they also modify and cross-link that collagen either through the lysyl hydroxylases or the lysyl oxidases or the Loxel type proteins to drive a much more fibrotic, highly cross-linked matrix that facilitates tumor cell matrix interactions. But we were also curious to understand if it would modify the extracellular matrix immune cell interactions. And in fact, we've observed exactly that. And I'll walk you through some of the data that we've recently published as to how we think that resistance to immune checkpoint blockade can actually be mediated by some of these changes in the tumor microenvironment. So this just defines some of the behavior in our models, where in these models, we find that they are transiently responsive to single or even combination immune checkpoint therapy, whether it's anti-PD-L1 or anti-PD-1, the results are the same. And what you can see here is obviously in the blue curves, these tumors are transiently responsive to the therapies for a period of about 6 weeks. That response is completely ablated if we deplete the CD8 T cells so that we know that this is an immune-based response. And so this is lost over time. So this is very similar to what we see in patients who have a progression-free survival advantage with the checkpoint therapies, but that don't convert to a durable long-term response. And so in looking at these models, and this is a similar growth curve as shown here in the upper left, what we realized is that there was a difference dependent upon when we started the treatment in the tumors. The earlier one starts the treatment, the more effective the treatments, even though they become less responsive over time. And so both by proteomic profiling as well as RNA profiling, one of the things that we found to be quite striking is that the many markers of the extracellular matrix, including all of the collagen isoforms, were substantially upregulated. We found this to be true pathologically when we look at untreated tumors early on versus later, as well as tumors that are treated with either of the checkpoint therapies against PD-L1 or anti-PD-1. In each of these cases, we find that over time, the collagen deposition and collagen cross-linking increases dramatically. We find the same thing to be true in the autochthonous tumors in the lungs of these genetically engineered models. And again, it's regardless of which of the checkpoint therapies one applies to these. And so we wanted to understand whether or not this was just an association, as we had seen in some of the patient data sets, or really if there was a cause and effect here. So there are multiple ways that we and others, such as Hal Chapman at UCSF, have defined the ability to either genetically manipulate the lysyl oxidases or to inhibit them pharmacologically with drugs such as ellagic acid. And so when we did this, if we just knocked down lysyl oxidase 2 in the tumor cells, we found a modest response in terms of the growth kinetics, but a much more pronounced decrease in the exhausted CD8 T cells over time, suggestive that there may be an association between these two. Strikingly, when we use ellagic acid to inhibit the lysyl oxidases and the lysyl oxidase dependent collagen cross-linking, it not only decreased, obviously, the collagen is shown here in panel B, but it also then dramatically increased the effector CD8 T cells that are present in the tumors, and it decreased the exhaustion phenotype of these as defined by PD-1 and TIM3 co-staining. And then strikingly, in addition to affecting the primary tumor growth in these, it also almost completely ablated the ability of these really aggressive tumors to metastasize. Strikingly, when we looked further at the tumors by immunohistochemical staining, we find that both in the primary tumors as well as the metastases in the lungs, that there was a substantial increase in the infiltration of the CD8 T cells, and that was true both in the periphery of the tumors as well as the interior of the tumors. So just by inhibiting lysyl oxidase 2 with ellagic acid, we could see dramatic increases in the ability of the effector immune cell subtypes to get into these tumors and to prevent outgrowth. And so we were curious as to what might be driving this differential phenotype in the lymphocytes and the tumors. In one of the long studied leukocyte receptors that is actually broadly expressed on immune cells is LAIR1. It specifically recognizes a repeat motif in collagen, the glycine, proline, motif. And in fact, it's actually been shown in LAIR1 knockout mice that they don't have any change in the numbers of the CD8 T cells, but they actually have an increased activated memory and effector population. And this appears to be in a mechanism that is dependent upon downstream SHP1 as an effector molecule downstream from LAIR1. And at least for these studies, we had several different ways that we could go about testing this using a drug that's specific for SHP1, or by using LAIR2, which is a decoy receptor that's actually found in humans, but that mice do not have. And so in this particular case, we were able to take the syngeneic tumor cells and express LAIR1 in these and show, as shown in the blue line, when they were just grown by themselves, there was some effect of just having LAIR2 being expressed by the tumor cells as a decoy. But when we combine this now with anti-PD-1, there was a dramatic increase in the suppression of the primary tumor growth as well as metastases, as shown in the aggregates here and the individual curves across the bottom. And again, strikingly, what we find in these particular experiments is that the effector CD8 T cells within these tumors are really very high now, on the order of 3-fold higher than in any of the single agent treated tumors, and that the immunophenotype of these CD8 T cells is a factor in and dramatically suppression of the exhausted phenotype. And again, when we look at these tumors, either on the periphery or in the central sections of these tumors, we find that there is significant increase, suggesting that really these effects that we are observing of the matrix are really specifically due to the LAIR1 receptor. We performed similar studies with the SHP1 specific inhibitor. And again, we find that there's some effect of the single agent by itself to drive the phenotype of the tumor cell growth and metastasis, as well as the infiltration of the T cells. So although this is interesting in terms of an overall mechanism, the question does arise as to whether or not this appears to be true in patient subsets. So returning to patient subsets, we stained them for and scored them for their collagen expression, as well as for the presence of CD8 T cells and markers of exhaustion such as TIM3, and find that there is a good correlation between the levels of the extracellular matrix in terms of the collagen isoforms that are present, and inversely correlated with the CD8 T cell and TIM3 expression. And this is true if one looks at, as shown here, in tumor tissue microarrays, where we are able to look at small sections, or if we take full sections of these tumor and score multiple areas of the full sections in these various early stage lung cancers. The same is true if we return to the TCGA. Here, obviously, we don't have the ability to take samples from the TCGA and perform the immunohistochemical stained approaches, but if we look at RNA profiling, what we find is there are dramatic correlations between the expression of the collagen isoforms and layer 1. And similarly, there are very high correlations between the collagen expression and TIM3, a marker of the CD8 T cell, of the exhausted T cells. Finally, in the absence of databases specifically for lung where there are pre-treatment and on-treatment biopsies, we went to melanoma data sets that are published to see if it looks like these markers are suggestive of response to checkpoint therapies in those cases. And the data shown in panels A and B demonstrates that at baseline, for patients that have high levels of the collagen isoforms, that they are less likely to respond to the checkpoint therapies. But importantly, when the pre-treatment and on-treatment biopsies from these particular patients are looked at, what we find is that for those patients who have an increase in layer 1 while on treatment, those correlate very nicely with an increase in the TIM3 markers for the CD8 T cells, and that this is then, as shown here in panel D, predictive of their long-term survival. For those that have very high level, increasing levels of layer 1 and TIM3, they have poor overall survival. So this brings us to our working model of how the extracellular matrix, which we believe in many ways is actually directed, and these changes in the matrix are directed by what's happening in the tumor cells, actually has multifaceted effects, not just on the tumor cells in terms of their ability to be activated and migrate and invade, or even in the ability to drive angiogenesis, but even more profoundly on the ability just in the natural history of these diseases to drive immunosuppression. And then, of course, importantly, in our ability to effectively recruit the immune system in the face of immune checkpoint therapies. So based upon how the extracellular matrix is laid down and cross-linked, we think that there are a number of pharmacological opportunities either to target the enzymes that drive this deposition and cross-link, or potentially downstream to target some of the receptors on the immune cells that are suppressed from these stromal checkpoints. So I thank you for your attention this late evening there in Europe and mid-afternoon here in the States. I'd like to thank the individuals in my lab, obviously all of our collaborators here and at other places, and the ICON team who really drives a lot of the patient-derived data sets and outcomes, and the NeoStar team, as Dr. Cascone outlined earlier today. Thank you.
Thank you very much, Don, for a great talk. I would ask for people to put questions in the Q&A box. I have a question here from Paul Hoffman. What is the toxicity of drugs targeting the ECM, for example, towards organs that are rich in extracellular collagen physiologically?
So that's a good question. Thank you, Paul. So the short answer is we don't completely know, but at the end of the day, it will come down to how one targets it. So for instance, ellagic acid is actually being used currently in patients who have interstitial pulmonary fibrosis, IPF, and it has been studied in a window of opportunity trials for patients who are going to transplant. So Hal Chapman's group at UCSF has used this and treated patients, and then the tissues from their lungs at the time of transplant can then be evaluated. And in those cases, what they have found is that not only is the drug tolerated really very well, I mean, patients are able to go to a very significant surgery and recover well from surgery, but in addition to that, in analyzing these tumors, they've actually shown that the fibrosis is significantly decreased. So we think that certainly in patients who have metastatic disease, that these drugs may be tolerated and we may be able to give them to them without significant issues, but that we may even be able to bring it into an earlier stage setting where patients, are getting curative treatments.
Great. So again, if there are questions, please submit them in the Q&A box. I will ask a question, Don. as someone who does actually more GI pathology than lung, personally, I look at a lot of metastases from tumors. And so I notice often that the primary tumors in the metastases have very different dynamics in terms of the amount of fibrosis and sclerosis that they show. So I wondered if you've looked at any pulmonary metastases to lymph nodes or organs and seen and looked at the matrix behavior in the metastatic setting.
So we haven't. That's something that we're trying to do. Part of this work is actually built into our lung cancer spore program. And so we are trying to take patients, both the early stage data sets that I've shown you, but also patients that recur over time, and then metastatic data sets that we have to answer questions along these lines. Because you're right, there can certainly be differences in the dynamics between tumors at various sites. And as such, how we would position drugs that target these interactions with the microenvironment, and especially the matrix, may be different if we find that it's only true in a primary site versus also true in metastases.
And there's a follow-up question from, thank you for the answer. There's a follow-up question from Paul Hoffman again. Any data concerning fibronectin?
So experimentally, we don't have any data concerning fibronectin, although I think it's potentially very interesting. We do have some hints of signal from the patient data sets, but it's hard to know if simply because we haven't done the experiments, if it's a real driver there, or if it's just that many of the modules of overall matrix remodeling are upregulated in some of these patient subsets.
Thank you. Thank you. Maybe one quick question I wanted to ask you about the biology, biochemistry of collagen in lung cancer versus any other. You mentioned fibrosing lung conditions. What's known about if there are any differences in the biochemistry, either of the collagen type or the type of cross-linking or the chemical modifications that differentiate lung adenocarcinoma stroma, collagenous stroma from other non-cancerous fibrosing conditions of the lung?
So in fact, there is an overlap because pathologic fibrosis has many of the same triggers or many of the same perpetuators. And in fact, patients with interstitial pulmonary fibrosis, even if they don't have any other exposures, they've never smoked or what have you, are actually at increased risk of developing lung cancer over time. So many of the underlying fibrotic pathologies are really very similar.
Thank you very much. If there aren't any more questions, I want to thank Don again for a wonderful talk.